Hello, my name is Brian Gippard. I'm the Research Director at the Integrated Benefits Institute, and thank you all for joining us today for our webinar on understanding the business value of the patient-provider relationship. Today, we're very fortunate to have a number of speakers today. We're going to start off with Adrienne Sabati, PhD candidate in health policy economics at Harvard University. She executed a study that was funded in part by the Integrated Benefits Institute. I'll tell you a little more about that. She's going to describe her findings, and then we are going to be joined in conversation by an esteemed panel of accomplished chief medical officers. Wayne Burton, who is the chief medical officer from American Express before his retirement. Pam Heimel, the CMO at Walt Disney Parks and Resorts. Tim Kowalski, chief medical officer for Progressive Casualty Insurance. And myself, your humble host. Again, I'm going to say a little bit about the Integrated Benefits Institute for those of you who are not familiar with us. Then I'll tell you a little bit about the origination of this research from IBI's perspective. Certainly it was a long time coming from Adrienne's perspective. I'll hand it over to Adrienne at that point, and she will share the key findings from her study. Afterwards, I'm going to do my best to convince you that there is some application of her information for employers and for this issue of employer health and productivity. Then we're going to turn it over for the real action, which is the experts from the employer side, people who really have to implement these kinds of programs and who have a different point of view on the research findings than, say, an organization like IBI might. So a little bit about IBI. I'll be pretty brief here. We've been around for about 25 years. We are a nonprofit research organization focused on workforce health and productivity. What we really are, however, is the hub of a network of experts and professionals who work every day to make sure that employees are healthy enough to be on the job consistently, putting in a really good performance. If we have a core message, it's that everybody recognizes that illness imposes costs on businesses. We always try to emphasize the ways in which we can bring evidence to light that shows how a healthy workforce actually creates value. They create value by being always ready to go, always ready to work, able to be on the job consistently, putting in their best performance, doing all the things that actually make a business a business. A little bit about IBI's fellowship. So what we're going to see today are findings from the second study that was supported by IBI's Thomas Perry Fellowship. So in 2017, IBI's board of directors elected to create a fellowship grant in honor of its founder and president, Tom Perry. And the intent was to support the work of promising PhD candidates who were doing research that complemented our own health and productivity focus. We're really trying to get out of our normal lane of absence, disability, and so on. And so we selected 2 applicants for the first round of the fellowship, which is really based on their creativity and the rigor of their work. Our first fellowship paper to come out of this was from Adelina Wang from the Stanford Department of Economics. And her work linked the quality of hospital care to Danish patients' subsequent earnings. And it suggested strongly that where people are able to get their care is going to matter for their ability to return to work, which of course in turn impacts employers' business operations. And from that study to this one, I see similar implications to what Adrienne's going to talk about today. Her findings are really going to drive home this interconnectedness between the performance of healthcare systems as healthcare systems, but also as businesses, between their performance and the performance of the larger business community. Adrienne Sabati is completing her work at PhD, or her PhD work at Harvard University School of Public Health. After that, she will begin a fellowship with the National Bureau of Economic Research, followed by a faculty position at the University of Notre Dame. And Adrienne, if I've got any of that incorrect, I know that you'll correct me on it. So over to you, Adrienne.
Okay, so as Brian mentioned, my name is Adrienne Sabati, and in about a month, I will have finished my PhD and I'll move on to a postdoc at the National Bureau of Economic Research. Let me make sure I can get this to work. Oh, there we go. Okay. So today I'm going to give you a very high level summary of my job market paper. which is entitled The Value of Service Sector Relationships in Healthcare. So high level, this is going. Okay, so high level, the question this paper tried to answer was, do primary care provider, which I abbreviate by PCP, so do PCP relationships matter to patients? And the answer I find is yes. My strategy for doing this is asking, how are Medicare patients impacted by the loss of a PCP? You may be thinking, why do I care about Medicare patients? I have a commercially insured population. I show that basically every single group of patients I look at is impacted by the loss of a PCP, which suggests that these findings will strongly apply to commercially insured populations as well. Also, my Medicare data, the average patient is in their high 60s, and I think a lot of employers have employees who are in their 50s and 60s as well. So I think that these are can be considered as analogous populations. My findings show that patients value their relationship with a PCP at about $300 to $400 per year. The relationship appears to be moderately important for patients' health and well-being. So the loss of the relationship translates into an increase of 50 deaths per 100,000 individuals, and that the existence of this relationship keeps medical costs down. So when a PCP leaves, patients spend an additional $16,000 in Medicare costs per exiting PCP. You may be thinking, okay, but these PCPs leave all the time. What can we do about it? We can't stop people from retiring. And so I show that these negative effects are minimized in clinics that are managed as a team. And what's important about that is that patients have a backup relationship with a PCP that they can rely on. So how do we think about these implications? So first, the elephant in the room is COVID-19. We are in a COVID-19 world. And these results, I think, apply to COVID-19 in a number of ways. But one way is that patients are more likely to visit their emergency department if their PCP is unavailable, or if they have to rely on telemedicine, which may kind of impact their ability to see their main PCP or have really kind of a true connection with that PCP. Also, patients may be scared to visit a PCP and go to a clinic setting because they're afraid of getting COVID-19 in the office. And so as a result, they may wait until their condition gets out of control, and then they have to go to the emergency department. I also, kind of stepping away from the COVID-19 world, I also think these results are important from two lenses. First, from the hospital or clinic lens, when you lose someone like a PCP who has a relationship with patients or clients, a lot of those clients leave the firm. And so this may affect the profitability of hospitals and clinics who are just naturally losing workers over time. Also, as kind of, if I was a benefit manager, I want to think about my workers, who we can think of here as patients. And so when a patient loses a PCP, this negatively affects their health and well-being. And so there are at least two things I would think about as a benefit manager. And the first is, when I think about designing networks or what kind of insurance plans I should offer my workers, when workers change networks, this may increase costs because it artificially severs the relationships these workers had with previous providers. And actually, about 30% of commercially insured individuals change insurance plans in a given year. So that means that 30% of workers have the potential to lose a PCP in a given year. Also, there's been a large growth in on-site clinics. And my results suggest that having a clinic in your workplace that you can go to for basic care may actually decrease costs. So to make sure we're all on the same page, I want to say a little bit about the primary care context in the United States. And that this context actually suggests that the PCP-patient relationship may not matter. So first, PCPs provide a fairly standardized good. They often are a gatekeeper. They provide referrals to downstream services such as specialists, and they provide preventive care. So this may be flu vaccines, annual exams, preventive screens. This is also a context where electronic health records are extremely common. So that may suggest that whatever PCP I'm seeing as a patient should be caught up on my history or what's relevant to me. There's also been a large growth in narrow networks, which restrict patients' options, on-site clinics within companies, retail clinics, for instance, CVS and their Minute clinics, primary care provided by teams of providers. So patients may see a nurse practitioner for 4 visits a year, and then their primary care physician for 1 visit a year. And then also growth in clinic scope, for instance, the growth of multi-specialty clinics, as well as size, so larger systems. So the question I ask narrowly is, how are patients impacted by the loss of a PCP? As alluded to earlier, patients value these relationships. I show this in 2 main ways. First, that patients switch to specialists patients have a relationship with for primary care long-term when they lose a PCP. So this is really patients switching to the more expensive specialist for primary care, like flu vaccines. I also do a separate analysis where I look at PCPs that move within 300 miles of the first clinic, and I show that patients drive an additional 233 miles per visit in order to maintain that relationship. And backing out kind of what does that mean in terms of costs with gas and wages, I get to a number of about $300 to $400 per year, which is presumably a lower bound. So how do I think about that as a benefit manager? So if I want to switch all of my workers to a new insurance plan, which requires them losing access to their previous providers, this means that patients would have, or workers would have to be compensated $200 or $300 to $400 to be just as well off in the new plan. I show that the relationship is moderately important for patients' health and well-being. When patients lose a PCP, they receive less preventive care long-term, which kind of relying on the clinical literature here, a decrease in, let's say, cholesterol screening leads to an increase in about 50 deaths per 100,000 individuals long-term. So it's not a lot, but it's not zero. I also show that adverse events increase in the short run, namely emergency department and inpatient admissions. This all suggests that the relationship keeps medical costs down. So there's 2 pieces here. First, patients are switching to the more expensive specialist for very basic care like flu vaccines and preventive screenings. And second, patients are increasing their use of emergency departments and inpatient settings, which is costly. And so this leads to patients spending an additional $5,000 and Medicare spending an additional $16,000 per exiting PCP. So let me just show you high level some of these results to make these the high level take homes more concrete. So I'm asking, how are patients impacted by the loss of a PCP? And I identify that impact by leveraging PCP retirements and faraway relocations. So we want to think of a market where the PCP just disappears, that the PCP vanishes, patients cannot follow them. I match departing and staying PCPs, and this is just to take care of differences between leaving and staying PCPs. For instance, you may be worried that a leaving PCP who, let's say, is an 80-year-old PCP who's retiring may be different than a 40-year-old PCP. And so I match them to just take care of these differences. And then I use something called a difference in difference design to compare patients' healthcare utilization and outcomes. And this just compares treatment and control patients over time. And so what do I find? I find that primary care visits, which is really, we're looking at the disappearance of a PCP, So the natural place to start is what happens to primary care visits. And this graph shows that primary care visits decreased by about 17% for at least 4 years after the loss of a PCP. And so to stay high level here, this black line is just showing that it starts around 0, which just means there's no difference between treatment and control patients. And then it kind of drops off a cliff and then stays low indefinitely. So this shows you something about the primary care visits, and so what is going on outside of the primary care context. The first panel shows that patients switch to specialists. So the black line, again, are the primary care visits we just saw on the previous slide, and I've overlaid this blue curve, which are specialty care visits. And this graph shows that there is an offsetting increase in specialty care visits when patients decrease the use of primary care physicians. And so they're switching to specialists. And so what are they using specialists for? The next panel shows that they're using specialists for primary care visits. And so the outcome here are preventive screens. The black line shows preventive screens by PCPs, which decreases. Meanwhile, preventive screens by specialists increases. And this increase in the screens by specialists is about a 32% increase relative to their baseline rate, because specialists really do not do preventive screens. So what else is going on? This next slide shows that emergency department visits increase by 4% 1 year after a PCP's exit, and that half of this increase is driven by primary care treatable conditions. The first panel shows this immediate jump up in emergency department visits, which then comes down a little over the subsequent 2 years. And the second panel shows that the shape is similar for primary care treatable conditions, suggesting that much of this increase is driven by these conditions that were previously treated in the primary care setting. And now Brian Gifford is going to discuss what this means for employers.
Thank you very much. I have to tell you that from the first time I read this article, when I see those drop-offs in people continuing to seek out primary care and the duration of that, 4 years after the fact, the drop-off is still persists. I just kind of shake my head at that. So again, why does this mean now? Thank you, Adrian, for the findings, and thank you for the study. And also, when I first read this study, my first inclination was say, I know it's important, and it's important for the Medicare population, a really large sector of the workforce, or a really large sector of the population. But then I started to think about how might these lessons apply more generally to a commercially insured population. And what I start thinking about, as always, with IBI is the patient as a patient on the one hand, but also as a key component of the workforce on the other hand. So in this case, we can really see how, in this respect, patient outcomes are linking the business value of healthcare organizations to the larger business community. And they do it in a couple of ways. One is, first and foremost, and Adrian really zeroed in on it, is that clinics and health systems themselves are employers. Right now, 1 in 9 employees in the US are working in the healthcare sector. And so disruptions in the patient-provider relationship threaten a clinic's business operation. She didn't go into that quite so much here, but those drop-offs don't necessarily reflect a return of business to the clinics, quite frankly. I also, as I read this, I wonder how these kinds of relationships actually apply to other organizations. Now, in Adrian's paper, she talks about how it might apply to banking. I think about how it might apply to, for example, consulting firms. We know that client relationships are key in other kinds of industries, and we know that they might be disrupted similarly. if we have a principal contact or a critical team member who requires a leave of absence due to illness. What is being lost? I think the term used in the paper is tacit knowledge. Everything that somebody knows from their deep, long association with a client is going to be lost, sometimes temporarily, sometimes permanently. But in any case, if we're talking about an exit due to a health issue, we know that that's going to be preventable. Okay. And finally, I started thinking about how network turnover might cause disruptions in the healthcare relationships, and how that might place the health of employed patients at risk. And so if we're thinking of how this drives up the cost of, or the use of costlier services, if we're thinking about how an increase in emergency department visits for routine primary care might not just be an expensive alternative, but it might be a way that is signaling to us a decline in overall health quality, we can see that this is not necessarily a Medicare story, and it may in fact be telling us something very important about what is going on in other areas that we have not yet analyzed. Okay. Now, we released a summary of this article for IBI's membership, where we zero straight in on Adrian's findings, and that we also are going to zero straight in on how this might be applied to a commercially insured population in the US context. As IBI always does, we will come up with research findings, or we will summarize research findings, but then we turn over the report to the experts out in the field of health and productivity. We come up with a number of pieces of practical guidance for employers. I won't go into these in great detail. The report's available, and you're free to read it. What I would like to do is start posing some questions to the kinds of people who give IBI advice, who really can tell us what should we be communicating to employers to help them think about research findings such as Adrian's, think about research findings that IBI sometimes produces, and how they might apply that. So again, we reached out to a number of people for guidance in the documentation, but today we are very pleased to have both Wayne Burton and Tim Kowalski and Pam Heimel with us to get their take on a few things. So if I might start out with a few questions, and then feel free to provide your own questions. We have in real time, you will see, if you're familiar with the Zoom app, you can click on the Q&A box, type questions to it, and we'll be happy to relay those to our panel. So just to start off, can I give one question to Wayne Burton? So Adrian's research is focusing on disruptions to the primary care physician relationships with their patients, and the expert guidance in IBI's summary really stresses the importance of what is termed medical homes. If you want to say a little bit about medical homes, but also what's the implication for people who don't have a primary care physician, and what plan sponsors, particularly employers, can do to help them establish a medical home.
Thanks very much, Brian. First, we know that medical homes are important where they exist, and right now it's sort of spotty around the country where they have, but it's a growing model. And the model is important for all the reasons that Adrian eloquently did in her research. The health plans, many of the health plans have medical homes or accountable systems of care, so that everyone is working together and there's a communication, specifically using the electronic medical record system. So what can employers do to help employees link up to a primary care physician? And I view this, and we've always viewed this, as part of not only the benefits, but also the health and well-being of employees. Excuse me. So we would have incentives for employees to see their PCP once a year, or for certainly either an annual exam or for some other reason. And in a company like American Express, where we would have on-site physicians, nurse practitioners, telemedicine, as well as free preventive services. And the American Express, like a lot of companies, we had a high deductible plan in place since 2009. So there was an incentive to participate and to have a PCP and understand the importance. Now, with that said, one thing we realize from a number of studies now that younger employees don't have a primary care physician, but by the time you get to 65 Medicare age, certainly 90% or more of that population has a primary care physician.
Good, understood. Tim, this issue of the primary care physician is my understanding, correct me if I'm wrong, and anybody please, Adrian, you may correct me as well. There are a lot of people who don't have a primary care physician, isn't that correct? I mean, it might be high in the Medicare population, but in the larger commercially insured population?
That is correct. It's, you know, depending upon what your population is, when we look at them, there are sort of some standard attribution algorithms to determine if you're engaged with a solitary physician to guide you through everything. And it's somewhere in the neighborhood of 15 to 20% in our commercial population does not have a primary care physician. We term those the medically homeless.
The medically homeless. The first time I've heard that term. I'm thinking about one of the other implications of Adrian's work, which is this focus on the team-based approach. Can you say a little bit, Tim, about potentially what employers can do to both cultivate this team approach, but also to what this entails in terms of backfilling physician primary care with other types of providers, nurse practitioners, pharmacists, physician's assistants?
Yeah, I think that's a great question, Brian. And again, I just give kudos to Adrian for doing the work she did, because it really corroborates a notion that any of us that have been in the world of healthcare as long as I have and some others know is true. And what this notion really is, you know, Hippocrates said many years ago that it is more important for the physician to understand the person who has the disease than for the physician to understand the disease the person has. And what that really means is that although you need to understand the science of medicine, the art of it is applying it to the individual and guiding the individual through their journey when they are not well and they are, you know, stricken by some kind of disease. And for those of us in the employer space, one of the biggest things right now is everybody wants to be your navigator. Everyone realizes that at least the system in the United States is very fragmented, and leaving people to their own devices, they don't necessarily end up in the best care, getting the right care at the right time from the right person. So having a team-based approach, which is what this patient-centered medical home is, helps you through all that. When you actually look at the history of the patient-centered medical home, it goes back 40 or 50 years, and it started out for pediatric children that had significant problems that required a number of areas of specialization to coordinate to determine the best outcome for them. And this sort of percolated along in the background, and maybe over the last decade or so, people realized that this is a good concept, and they developed it further. And one of the things that I'd recommend if you're looking for a primary is to look for an accreditation in patient-centered medical home. And having this accreditation means that the care providers, and it's not just physician, it is all the people on the team, are coordinating their care. They're all practicing at the highest scope of their training or education to help the patient through their journey and what their needs are. So that may be anything from intake personnel to support staff of medical assistants to nursing staff to docs to mid-level providers to pharmacists to behavioral health specialists, all coordinating to get the best for the patient. Unfortunately, the care in the United States tends to be very organ system based. So when you see a specialist, they'll talk to you about their heart, but they won't pay attention to the rest of your needs. And as such, that's not in your best interest. And so, you know, the phenomenon that Adrian showed so eloquently of you're percolating along your primary care retires, all of a sudden the preventive measures go down, but you stay perhaps with a specialist who's taking care of one of your chronic diseases. And although that might be okay for your chronic disease, it's not good for you overall, and you don't get prevention stuff done. And one of the problems with our system in the US is that we are very disease treatment oriented. When we contrast ourselves with other systems in the world, the other systems in the world spend a lot more time on primary care, and they get a lot more value out of it, because the value that's created is really the outcome for the patient plus their experience, all divided by the cost. And we all know that costs are lower in other countries throughout the world. Quality is actually better, and the experience is actually better. So what can employers do? I would echo what Wayne said, is really try and incent people to develop a relationship with folks. You can do that by providing, as we do at Progressive, on-site medical clinics that are patient-centered medical homes. But you also construct contracts and provide benefits that incent individuals to get into a system so that they have a primary. And then you also have to, when you're constructing this, realize that there are generational differences. And so, the younger generations, be they, the Gen X's or the millennials or what have you, Gen Z's at this time now, they get engaged differently. And that's really what a primary care provider does for you, is helps with the engagement. When you talk the numbers, the most recent thing I saw is that the average primary care is worth $14 million of downstream spend in the health system that they're worth. So even though they're controlling a panel of maybe 2,000, 2,500 patients, they really account for a lot of spend. And they obviously account for a lot of direction where people go. So it's very important to get someone that can help you engage in the system and navigate and direct you to where you should go, when you should go there. So there's a lot that can be done with plan design. There's a lot that can be done with benefits offered on site. And you have to realize that what worked previously is not going to work today, because everybody has different channels and portals for communication and engagement. And you need to provide kind of a cornucopia of ways of people to get into the system.
Thank you, Tim. And before I start talking about how much disruption we might actually see in networks used by employer-sponsored plans, I want to go back to the point you had made about incentives. And I want to put this question out to the entire panel, including Adrian. We know that Medicare is experimenting with capitated fee models where clinics and hospitals are going to assume different shares of risk and savings based on the quality of the care they provide. And so that's one incentive structure. If this should show promise, what would it take, or what might it take, to see it applied for a commercially insured population, which, as you pointed out, Tim, it's a lot of different employer plan sponsors, so it tends to be very fragmented. I mean, what might it take to see that actually implemented?
Well, I'll jump in, Brian, to get started. Certainly, Progressive is basically a national US-based organization, and we have different geographic footprints for where our employees are concentrated. A large portion's in Ohio, to a lesser degree, Florida, Texas, and Colorado, but we have people in every state. So to truly have an impact on creating these value-based arrangements, you need a significant portion of people so you can understand whether a relationship is actually moving people in a positive direction in terms of clinical quality, and you remove adverse selection. So you need like 5,000, probably minimum, more likely 10,000 covered lives in an area to do something. Then you also need a partner in that area from an integrated health delivery system that's willing to have that conversation. Although CMS is playing around with value-based arrangements, it's currently only 3% of the overall payments to providers is at that level. And in commercial plans, it's probably around the same number. And the value-based arrangements are not dual risk arrangements for the most part, the level 3 ACO arrangements. For the most part, it's just you'll pay me to do some quality reporting. So we really need to move the needle on that, and really need to find a partner, and really need to talk about dual risk sharing in this kind of relationship to go forward. I think, for people like us, we would have an umbrella coverage for throughout the country, but we would look for opportunities where we have a significant concentration of our people, and we have a significant potential partner and a health provider that we could do that.
And I'd like to add something to what Tim mentioned, because back in the early 1990s, I founded a group of interns at Northwestern. We teamed up with others in the hospital, as well as there were literally hundreds of thousands of practices around the country that did take risk, financial risk. And unfortunately, back then, it did not work because some of the reasons that Tim mentioned. In addition, the data systems to calculate the risk weren't there. And the other problem was that primary care physicians were not trained to do enough services that would generally be done by specialists. So that model, of course, part of the HMO model and other models, it didn't work at that time. Well, page forward now, 25 years, I think we have better systems certainly in place, better information systems to calculate the risk and determine the financial risk. And then we'll have to come up with a different model so the risk is not primarily on primary care physicians. And I think the logical, or at least one option, is the accountable care systems or the medical homes that have a broad-based integrated system of providers that can take that financial risk. And to Tim's point, you need a large number of patients to be able to actuarially take care of that risk and assume that risk.
Thank you. My original question about disruptions in the market was really going to be about how often do we actually see networks under commercially insured populations. How much do networks really change? But one of the audience members reminds me that we are seeing a lot of disruption right now, insofar as, one, a lot of people are losing access to their primary care physician. A lot of people can't go and take care of their, really take care of their regular health conditions to begin with, if they don't or can't go to a doctor. And I know this is going to be purely speculative, but that tends to be the environment we're in right now. What role can employers play to make sure that people are still able to take care of themselves, whether or not they've been furloughed or laid off? And that's going to be critically important for reducing unnecessary emergency services. Is there anything that benefits that you've been seeing or hearing about right now? The way that benefits are constructed can really help along with this?
Well, employers, a number of employers, certainly Tim's, ones that I've been associated with, have provided a lot of preventive services at the workplace through their on-site clinics or bringing in vendors. And perhaps there'll be an opportunity for telemedicine too, in terms of certain preventive services like skin exams or concerns about skin lesions. So I think going forward, when employees come back to work after a period of time, to enhance those kinds of services that are available at the work site, because one of the reasons why employees don't participate is time away from work and all the other things that we have to do nowadays. So that would be my thought.
Yeah, and I would echo what Wayne said. I think obviously you look at the COVID situation and you can kind of view it as, this is horrific and it's a pandemic, and rightfully so. But I always view the major things like this as change agents and an opportunity to change. And what I think you're going to see in this, especially the primary care arena, is a marked adoption of telemedicine as a way to provide health care. When I looked at our clinics on site, we were about 85% in-person care at Progressive, about 15% of virtual care. And, we flipped a switch in a matter of 2 weeks when we moved from 4,000 employees working from home to 40,000. And just now we're about 95% virtual care. Also during this time, as you can imagine, most people were avoiding anything elective in the healthcare system. But as we come back, people are going to realize the convenience of the telehealth without a loss of quality for a large variety of things. I'm not saying everything. You still need to, as a health provider, put your hands on people and do certain things. But 50, 60% certainly can be done through telehealth, and you're going to see that. Wayne alluded to dermatologic services as one. There are some innovative companies out there. I won't give a commercial plug, but one who provides a on-home device that you can look in people's ears, look in their throat, listen to the heartbeats, measure the temperature, measure heart rate, measure oxygen tension, do an EKG, and they're offering this service. So the reason telehealth wasn't adopted in the past was in part health providers didn't want to do it because the telehealth services are reimbursed about a third of what the in-person services are reimbursed. The second piece is health insurance companies didn't want to offer this as another service to pay for. And so when you have those kind of conditions in place, it doesn't get adopted. It's not because it wasn't a good thing to do. It's because the economics didn't work out for the insurance companies and for the health providers. Well, now people have got a taste of the fact that you can do this from a virtual space and do it well. And I think more than ever, you're going to see adoption of telehealth, and that's going to be with the cost reduction associated with it. So it's going to be a good thing. I think in regards to your first question, Brian, we have seen some companies, even though they are non-essential businesses and are furloughing employees, a number of them are maintaining the health benefits for folks with the hope that we will get through the pandemic early phase and they'll be able to return to work. And I'll just give one plug for Dick's Sporting Goods is one that I'm aware of that has done that. Unfortunately, our country doesn't have universal coverage for everyone. That is kind of what it is, but to the extent that employers can keep their employees covered under benefits, even if they furlough them, I think that's a great thing. I know our organization, it just came out in the press today, we've moved $1 billion to our customers. We've advanced bonuses as well as advanced we have a thing called earned time benefit, which is kind of like time away that you can move in advance to take care of people in crisis. So I think a lot of companies, if they can do the right thing, they will do the right thing and help people through what hopefully is a few months in time before we resume some way of life. But I do believe that it's going to be a new normal. And I think more than ever, if you have a relationship with a provider, you're going to be in contact with that person, because if you look at the early treatment of COVID, there is no treatment per se. It's supportive care. And so your provider, by being in touch with them from a telehealth relationship, tells you to stay home and tells you certain activities to do to lessen your chance of getting infected and how to take care of yourself. You know, I happen to know Teladoc in the early stage of this had a 500% increase in their usage and a 6-hour average wait. And we flipped it around and provided service to people to just educate them. And that was calming in and by itself, and that was a valuable service. So I think there's a lot of things you can do. You focus on preventing illness in the first place, then you don't really need this, and you focus on doing the right care at the right time.
Yes, we are running a grand experiment, not of our choosing, and yet
Yes.
I'm with you that coming out the other end, there will be many opportunities for lessons learned. And I want to, before I let the panel and the audience go, I want to jump back to one other topic. This issue of on-site clinics. One of the things that we were faced with shortly after the passage of the FFCRA, which extended paid sick leave benefits for people depending on the size of the company. It seems like, and anybody on the call can correct with me if I'm wrong, on-site clinics principally are going to be for companies with a sizable number of employees in the same workplace. So presuming that we're going to get back to something like normal and there will be physical office spaces again, for the most part, can on-site clinics, do you see any opportunities for them to be scaled up by opening up to other firms, for example? Is there a way for some of the smaller firms, and when I say smaller by the FFCRA, we're still talking sometimes 400, 300 employees. Are there opportunities there?
Well, yeah, I'll start on that. The answer to that is yes. You know, the trend in terms of employers of having some type of relationship with on-site clinic, whether they employ the staff themselves, whether they have a turnkey opportunity with a number of vendors in this space, or if they even link to a healthcare system to provide that service, is increasing. For the large size employers, which I think is what you're alluding to, Brian, it's somewhere in the neighborhood of 25 to 35% have an on-site presence with an intention of 50% more to increase that. But then you get in the phenomenon of how can the slightly smaller mid-sized employers do this? And given the advent of telehealth, what you're seeing is companies like Eden and Crossover will supply primary care in a virtual space initially. And when they have a critical mass, they will put a near site clinic near the companies that they are serving. So if one company has 400, another one has 600, and another one has 300, they'll put a location in the area to provide the services that need to occur in person. The beauty of this is that you align incentives with the on-site clinic with your organization. And those incentives are to provide high quality care, high customer satisfying care in a cost efficient fashion. And when you look at the ACOs that have done the best in terms of this CMS model, it's not those that are part of a large integrated health system that provides all the tertiary care. It's those that have large primary care bases that pick and choose services from the tertiary care. So in a smaller way, by having your own primary care on site and having that person be the trusted clinician, the navigator, the very stuff that Adrian is referring to, and picking and choosing who provides the best care, that's where you get not only the best satisfying care and the best clinical outcome, but the most cost-effective care if that's what you're incenting. I mean, our clinics, we employ our providers, and on average, each year we look at this number from our national carrier of people that are attributed to our patient-centered medical home clinics at Progressive, compared and contrasted with our people that go elsewhere outside of Progressive for their care. We have a $1,400 per person per year advantage. We have about 10,000 people attributed to our clinics. It's 14 million bucks. You subtract off the cost of running the clinics, and I turn $10 million over our CFO every year. He's kind of happy with me right now. So, you know, you can do it cost effectively, but most importantly, you got to align the incentives, and the incentives are, you know, measuring clinical outcomes and measuring customer satisfaction. So there are ways to group people together. There are turnkey operations that will do that. And I think it's a thing that's coming now to a greater forefront. And I believe the COVID crisis is going to move this even further along. So I'll stop there.
Pam, considering that with the Walt Disney Parks, I mean, they have concentrated populations of employees. Is this something that has been discussed maybe since the COVID-19 pandemic or prior to?
I think it has. You know, there's certainly been conversations.
I'm sorry. I was asking Pam. Yeah.
Yeah. Okay. Sorry. I'm done.
I think she's still with us. All right. I can't hear.
She's been having trouble getting in.
Oh.
I just got an email from her.
Okay.
She's working with Carolyn.
Okay. Then let me go back to that final last question, and then if we can't get Pam in time, we can let the audience and the panel go. Thank you all for participating. I really appreciate it. I'm going to leave with one last question about, because as chief medical officers, I think about your role either in advisors or as people who are making decisions about other kinds of benefits, not just the medical, but short-term disability. Is considering that and this is a question from the audience, considering where we are now, just in terms of what we might see with the pandemic, are you thinking about anything such as what it's going to do to just the experience that you would see in short-term disability? And is this going to roll over into different kinds of implications for offering benefits, rate increases, but also in terms of coordinating the kinds of care for, let's say, some of the conditions that have complicated some of the worst COVID-19 cases. I'm thinking of diabetes. I'm thinking of heart conditions. Is this an opportunity to start thinking a little bit more broadly about integrating benefits?
Well, let me just start out at part of that. Integrated benefits is something that we've been involved with for many decades, actually. And I think it's important just to cite one part of the disability after these kinds of events. This event, we had some experience over the past years, is behavioral health, mental health. And my guess is that we will see an uptick in the need and use of behavioral health, mental health services. And it emphasizes the importance of the EAP, whether it's on-site or telephonic or video conferencing, because getting in to see providers can be a challenge time-wise and so forth. So I think that after the acute issues of the virus and the physical ailments, I think the employers will need to put in place additional resources for mental health.
And I would just add on and expound on what Wayne said. So my role in Progressive as Chief Medical Officer is really one of influence. I don't think I'm a decision maker in anything, but I provide clinical subject matter expertise into the context of the business, and then you develop a consensus decision. In the space of COVID, we've done a number of things, like for the next 90 days to not have any apparent obstacle. We've waived any co-insurance or co-pay or any type of deductible to have people access care across the board, whether that be for pharmaceuticals or whether that be for the medical issues. We've data mined our population from HDMS and looked at people that are at higher risk for a more adverse outcome. And even though we've moved all these people home, we've put together a way that should these people volunteer, they're going to be allowed to stay from home and deal with that effectively. We've made people aware to what Wayne just said. There's a ton of stress out there in regards to this. And, there's the true threat and the perceived threat of this, both of which create tremendous impact. And we've allowed anybody who's expressed concern whatsoever to work from home and be very lenient across the board in terms of their need for whatever their needs are. We also had a project underway to deal with what we were terming social determinants of employment. And although that was looking at reliable transportation and safe housing and some of these issues, this has flipped it around, and we're in a work from home environment, and a lot of this is around financial insecurities. So as I said, we advanced monies to people that's on a profit sharing at an early age to get the true money in their pockets quickly, and did a lot of things in the first 3 months. But as Wayne says, I think that this is going to be a tremendous change for people going forward. There's no clear evidence that this is going to be done come the summertime, and we have to think through what all the ramifications are and be flexible on what we can provide in benefits and be compliant and inherent with what the laws are going forward. So it's really a time of tremendous change, and as a Chief Medical Officer, we have the ability to influence it and provide the clinical background and the human background. And that's not to say the business types don't have that, but I think that's our role, is to be advocates for our people, and so we try and do that.
Brian, Pam is on, but is not able to unmute herself.
How's that? Pam, do we have you? Okay. Apologies for the technical difficulties. We really want to hear from Pam Heimel, and we're going to have other opportunities to hear that as well. Unless I'm the only one who can't hear her.
No.
Are you with us, Pam?
Can you hear me?
I can hear you at long last. Thank you for joining us. I still have an important question for you. I think of the workforce at Walt Disney Parks under normal circumstances. you tend to have people concentrated in a typical area or in a central area. I'm thinking of the parks themselves. Has the use of on-site clinics, have the use of the team-based approach that we were talking about earlier, is this something that Walt Disney Parks has considered, and or is it something that you actually already do? And if so, what have been your experiences with it?
Yeah, so we do have on-site clinics. We have 2 large ones in Florida, at least, where we have 80,000 cast members, and it's worked well. I was going to add to some of the telemedicine discussion earlier, because I think that is going to be a newer normal for many people. We've actually started working with some of our external vendors to even do telemedicine physical therapy and remote physical therapy and rehab. So I see us being able to deliver services in a very different way in the future, using technology that maybe hadn't been explored till now.
Okay. And I won't ask you to reveal any of the findings, but it seems like if you have parks all around the world, you have a nice, since we're talking about natural experiments, you have one almost. Have you or has the park considered looking at different outcomes for the places that have on-site clinics versus those that don't? I'm thinking of the Anaheim parks compared to the Florida parks. Is this something that might be in the works?
Well, we have a collaborative clinic up in Burbank with our where we have a smaller number of people. We're using a community clinic that is shared by a number of employers. So we are looking at those kind of opportunities.
Interesting. I'm gonna look forward to the research study that comes out on that one. We are almost up against the hour. I thank you all to the panel for being on board, for giving us really good, high quality and clear information on how employers might think of the findings that Adrian presented. I think in our Q&A, we went somewhat far afield from the things that she studied, but that's in fact the intent and benefit of the fellowship, again, to get creativity and rigor out there and bring it to bear on issues that might not always be obvious in terms of health and productivity. So thank you all. Thank you, Adrian. And thanks to the audience for joining in and for submitting your questions. I look forward to speaking with you again on the next webinar that IBI presents, which will be on a culture of health. Thank you very much.